Hello everyone and welcome to class. My name is Iris Torres and I will be facilitating this class for you on complications of labor and delivery and antepartum, with the focus being on pregnancy-induced hypertension. The class objective would be the nurse will be able to provide high-quality patient care and thorough assessment on patients diagnosed with gestational hypertension. They will understand the disease process, early detection, and prompt treatment of gestational hypertension, preeclampsia, chronic hypertension, and eclampsia to safely care for the patient. So we'll be moving forward with hypertensive disorders in pregnancy. Statistics show that hypertension is one of the most encountered problems during pregnancy, complicating 12 to 22% of pregnancies. Hypertension can lead to maternal and fetal morbidity. Hypertension is one of the leading sources of maternal mortality, approximately 17% in the United States. And the prevalence of pregnancy-associated hypertension increased from 10.8% in the year 2017 to 13% in the year 2019, while the prevalence of chronic hypertension increased from 2% to 2.3%, according to Ford et al. And I will be sharing my references with you towards the end. So hypertension diagnosis. If a blood pressure is systolic blood pressure of greater than 140 and or the diastolic blood pressure is greater than 90 on two different occasions at least 4 hours apart in a woman with previously normal blood pressures will be categorized as having hypertension. So the categories of hypertensions would be chronic hypertension, gestational hypertension, preeclampsia, eclampsia superimposed on chronic hypertension, preeclampsia by itself, preeclampsia with severe features, eclampsia, and HELP syndrome. So moving forward with chronic hypertension, the blood pressure, systolic blood pressure would be greater than or equal to 140, and the diastolic blood pressure would be greater than or equal to 90. This is predating conception, meaning before pregnancy. And with this, a woman can be taking medications before pregnancy, antihypertension medications before pregnancy. And this diagnosis is identified at less than 20 weeks of gestation. And it can actually go on up to 12 weeks postpartum. So gestational hypertension, with gestational hypertension, the blood pressure would be greater than or equal to 140 over 90 with no proteinuria. The onset of this blood pressure would be greater than 20 weeks of gestation, and the transient diagnosis with normalization of blood pressure by 12 weeks postpartum, so meaning that the blood pressure will normalize after the baby is delivered after 12 weeks. And this may evolve to preeclampsia. So we will be moving on to preeclampsia superimposed on chronic hypertension. So with this, this is characterized by worsening of the blood pressure and protein in the urine in chronic hypertension patients with the vascular or renal disease, with or without vascular or renal disease. About 25% of pregnant women with pre-existing hypertension develop superimposed preeclampsia. So one of the features with this is being diagnosed with chronic hypertension, but with the new onset of proteinuria. For these patients, we do a PIH panel, and the protein creatinine ratio would show greater than 0.3 milligrams per deciliter. Preeclampsia. With preeclampsia, there may be a decrease in blood supply to the placenta, which can lead to medical problems for mother and baby. Preeclampsia would be new onset of hypertension plus a new onset of proteinuria. The urine, they'll go ahead and do a 24-hour urine collection, and we will be seeing more than 300 milligrams within this urine. The dipstick, if we go ahead and dip the urine, we will show a +1 on the dipstick, and the protein creatinine ratio will be greater than 0.3 milligrams per deciliter. Some signs and symptoms for preeclampsia, it may include swelling of the hands and feet, dizziness, vision changes. Some women will see floaters, and an abdominal pain, which will be more in the upper quadrant, severe headaches as well. Preeclampsia with severe feature. This I did retrieve it from ACOG, which is the American College of Obstetricians and Gynecologists. I saw this chart, and it actually it gives us everything that we need about we need to know on preeclampsia with severe features. So they do talk about systolic blood pressure being greater than 160. And diastolic blood pressure being greater than 110 on 2 different occasions, at least 4 hours apart, unless antihypertensive therapy is initiated before this time. We will also see thrombocytopenia, impaired liver function that is not accounted for by alternative diagnosis. We will also see renal insufficiency. The serum creatinine concentrations will be greater than 1.1. And pulmonary edema, so patients will have difficulty breathing, new onset of headaches, unresponsive to medications, and not accounted for by alternative diagnosis, and again, visual disturbances. With eclampsia, with this, it is the final stage, I guess, if we leave preeclampsia untreated. So for eclampsia, we will see presence of new onset of grand mal seizures in a pregnant woman with preeclampsia. We will see new onset of seizures within 48 to 72 hours postpartum, generally not after the 7-day postpartum. And incidence with this is 1 in 1,000 deliveries in the United States. So HELP syndrome. HELP syndrome is hemolysis, elevated liver enzymes, and low platelets. So HELP syndrome is a life-threatening pregnancy. Complication is considered a severe variant of preeclampsia. So we will see signs and symptoms of headaches, nausea, vomiting, abdominal, again, upper quadrant pain that does not go away with any pain medication. Swelling, changes in vision, headaches, shortness of breath, difficulty breathing or gasping for air. There are some factors that put women at risk for developing HELP syndrome. Some of these factors can be pre-existing high blood pressure, diabetes, advanced maternal age, carrying multiples such as twins, triplets, and having a previous history of preeclampsia. So pharmacological therapies, one of them would be magnesium sulfate. So magnesium sulfate is the drug of choice in the management of preeclampsia, and this is of course to prevent seizure activities and should be used in all patients with preeclampsia with severe features or with HELLP syndrome. Pharmacological therapies, which are the antihypertension's first line of antihypertensive therapies, would be labetalol, hydralazine, and nifedipine. So this is a hypertensive crisis treatment algorithm that I was able to retrieve from ACOG. I will be sharing the link so you guys can have this in case, as reference, in case you guys ever need it. So it goes step by step on what to do in case of an emergency hypertensive crisis for our patients. And so, of course, it first starts with the magnesium sulfate that I had just previously discussed on, and then it moves on to the first line antihypertensive treatment. So first, it's the labetalol. Labetalol is a beta blocker, and initial dose should be given at 20 milligrams through the IV. And with this one, it's not to exceed 220 milligrams within the 24 hours. We do need to keep a close eye on the patient's heart rate because it does decrease the heart rate on patients. And we cannot give this medication on patients who have asthma. Once we do reach our target blood pressure, which should be in the ranges between of 140 to 159 systolic and 90 to 100 diastolic, we need to keep in mind that with getting the blood pressure below these ranges can cause a decrease in fetal perfusion. So that's very important to keep in mind as well. Another first line of antihypertensive treatment is the hydralazine. And hydralazine is an arterial dilator and should be given IV also. We start at 5 milligrams over 3 minutes, and then we can repeat it every 20 minutes until the desired blood pressure is reached. And this, for hydralazine, we should not exceed 25 milligrams in 24 hours. And another first line of antihypertensive treatment is the nifedipine. Nifedipine is only given if we have no IV access, and it is a calcium channel blocker. So how this medicine works, it relaxes the muscles in your heart and the blood vessels as well. The initial dose should start at 10 milligrams, and it should be repeated. It can be repeated up to 3 times within those 20 minutes, until the desired blood pressure is obtained. If for whatever reason the chosen treatment does not work for our patients, then we need to contact our doctors, being the primary OB doctor or the MFM doctor that's in charge of that patient. So this concludes my presentation. I hope you guys learned something from it and enjoyed what I have presented. And this last slide is just the references that I used for all my presentation. Thank you. Have a good day.